Now come to Dr. Nitin Verma, who's coming here from Australia, and he's going to give us a keynote address on high-dose Aflibercept, real-world experience in DME and RVO. And after that, we will have Dr. Malika. She's going to talk about management, her approach to management of RVO.
Thank you, Dinesh and Malika and Anand. It's always a great pleasure, and it's like coming home, coming here. So, but I'm going to talk to you about my early experiences with Aflibercept 8 milligrams. These are my disclosures, and also I'd like to thank Andrew Chang and Bayer for giving me some slides. Let's go back a little bit and look at the a few studies and what that showed us. When we talk about Aflibercept 2 milligrams or Eylea, and then the new Aflibercept HD or 8 milligrams, we find that there is an advantage using 8 milligrams in terms of durability and also potency of the injection. So you get good resolution, faster resolution, and longer intervals between injections. And so that means there is an advantage of using a higher molar dose. When we look at the extension, which means what happens after this formal study is over and then you go on to 156 weeks, and then those people comparing 2 milligrams with 8 milligrams, when at the switchover at 96 weeks, if you switch from 2 to 8 milligrams, it certainly does provide an advantage to those groups those people who are in the lower dose group. So switching from lower to higher does give you an added advantage in terms of reduced number of injections in the extension period. This is also seen in the in the central retinal thickness. So this is really about patients with AMD. As you go along with year 3, year 5, the number of injections reduces. This is something that we're quite familiar with. When we go on to DME, which is the photon study, now the difference between standard loading doses with Aflibercept 8 milligrams, when the studies were done, they used only 3 loading doses instead of 5. So it was the same way as you would do for AMD. And you'll see that the switching also allowed lesser injections in the 96 to 156 week mark. And also this was good for the central retinal thickness. What you see here in the yellow part of the graph, which is on the left, you see that there's a sort of a seesaw pattern, and then that tells you that the drug action wears off, and so it goes. Whereas when you use a higher dose, not only do you get a quick reduction in the central retinal thickness, but you also have less seesawing, so there's a lot of less fluid moving in and out, so that's telling you about the durability. And again, in these patients, the number of injections falls with time. So now I just share with you a few patients of my own. And look, we just got access to Eylea HD sort of middle of last year. This is the first year. So the first 2 patients are ones who just started treatment with Eylea HD rather than switching. Here's a patient who was first seen on the 16th of January this year. He had bilateral non-proliferative diabetic retinopathy with maculopathy, slight reduction in vision. He responded on the left side, as you see, within 3 injections. He's almost got a complete resolution of his edema, and a similar story in the right eye. So here you see that you get in this particular patient, he was well controlled, good model sort of diabetic control, good response very early in the piece, and there was no change in the intraocular pressures with time. Here's another lady with AMD who came in, commenced on high-dose Eylea, and you can see that in August 2024, and she had then 2 months later complete resolution of fluid, and that has stayed, allowing us to extend the intervals to 8 weeks and then 10 weeks and 12 weeks. So she's on that phase now. We follow a treat and extend to move her on, and that's her intraocular pressure, showing that even a higher dose makes no difference. A last patient who came in with what seemed to be a polypoidal vasculopathy. It's a 70-year-old female with visual acuity of 6/36. That's her fluorescein angiography and her ICG, and you can see her OCT quite clearly. She was started off on Aflibercept 8 milligrams And then we were able to increase the gap between injections to 8 weeks pretty quickly, and she had a good response. So, and you can see that also on the fundus photographs where the macular bleed is beginning to settle down. So we have a study called the Curios study where each center is analyzing 10 patients of their own and looking at how they responded to naive patients and also patients who were switched. And we find that there's a significant visual acuity and reduction in central macular thickness after the first injection. So look, these are very early data, in fact, only from one center, but that's the feeling you get after you analyze and see what's going on. So that 70% of patients achieved greater fluid control after just one injection of the drug, so telling you that the potency is much higher. And PEDs also, which are sort of, often don't respond to anything, seem to work quite well here. So patients really have a potential for quicker extension with the new medication. Now, if we come to patients who were switched, so this is a patient who was on faricimab and was not really responding even at 4-weekly injections, and then you can see that she just carrying on, and then we switched her over to Aflibercept 8 milligrams, and then slowly within a month she settled down, and then we started the extension to 6 weeks, 8 weeks. So we normally do 2 weeks at a time, so showing you a good response. Another patient who was on 2 milligrams for a long time, but is a retired doctor, wanted, saying, look, I can't come so often, do give me something else. He wanted to extend. So here's a patient who was stable on Aflibercept 2 milligrams and then switched over to 8 milligrams, and we are now in the process of extending the interval to 9 weeks. So he was on 10 weeks, so if it's on 2 milligrams, 10 weeks, we go to 8 milligrams, 10 weeks for a start, and then start the extension from there. So that was the right eye. This is the left eye, showing you that one can switch quite clearly. Another patient who has been through the whole pharmacy, she was on Eylea 2 milligrams from December 22 to August 23. She had a slight reduction with Eylea 2 milligrams, and then slowly the fluid started coming back. Then we switched over to faricimab, again, slight response, and then back again. We're not talking about extension, we're talking about response. She says, doc, all my patients, all my friends are on Eylea 2, let's try it again. So I said, I don't mind, let's go back. So we tried, and again, not much difference there. So she was humming along, vision maintained, but as you said, the SRF doesn't go. The fluid study shows that SRF we can tolerate, but what's better than having SRF is not having SRF. So we then switched over to 8 milligrams, and she did respond, and now we're in the process of extension. So, and that's her intraocular pressure. Here's your horror diabetic patient. He's a truck driver, poor diabetic control, sits the whole day, smoking, and you just look at him walking in and you say, that's a bomb walking through. This is going to be a difficult one. He's had PDR, for which he was started on Avastin, and while his laser was going on, and then he sort of left him on Avastin for his DME. Then slowly Avastin stopped working, said, okay, doc, that was, let's start with Lucentis, and then Lucentis worked for some time, and then he ran out of control there also and said, all right, okay, let's switch to Eylea. And so he was on Eylea, it worked for a little while, and then again, stopped working. Although I must say he stopped smoking also. His biochemical control became better. He lost some weight, not too much. And then we switched him over. You see the first two OCTs on the left. These two are, he's still running on Eylea. And then we switched him over to Eylea HD, and he's had a pretty good response. So he's been treated since 2011, and that's his intraocular pressure right through. So really, when we see that in this group of patients, when we upgrade, these are the group of patients who we upgrade to Aflibercept 8 milligrams from some other drug, although most of them were switched from 2 milligrams to 8 milligrams. And the reason for the switch was the idea to try and extend, although a third of them, a third of them was to do with the idea of extension, but most of them weren't getting a handle on the disease activity. And we found that one could actually keep the anatomy and visual acuity at least maintained, and found that there was a good response to switching even after one injection, as we saw in the naive patients. So, you know, these are initial days, but we don't have any safety concerns. The one concern that did come up was you're injecting a larger amount of drug, 0.07 rather than 0.05. Does it make any difference to the intraocular pressure? 30 seconds after intraocular injection, the pressure in the 8 milligram, which is the larger volume group, goes up, but then by 15 minutes, it's down. So this is a Swiss study, and our own study was very simple in our own thing. We took pressures at 1 minute, and they were between 38 and 57 millimeters of mercury, but by 20 minutes, it was all back. So no real concerns about intraocular pressure. And all of us who've used, Keynote or triamcinolone injecting 0.1 mil, we really never thought of all these things. So I think when Aflibercept 8 milligrams becomes available, its increase will be good in terms of using for DMO, for AMD, and then past the Quasar study for retinal vein occlusion. So that's where we are. So greetings from Tasmania. That's Wineglass Bay. So if you come there, this is kind of scenery you get to see. But thank you for your attention.
Thank you, Dr. Nitin. Any questions for him?
So I have one. Dr. Nitin, with the high dose, 8 milligram, the volume is not so much of an issue, but we're injecting that many more, drug molecules. Yes. Is there any concern about in AMD patients with a bit of, attendant geographic atrophy? Can that, with repetitively putting such a high dose, can that, accelerate the atrophy? Because this is something I asked this because in the CAT study, again, hopping back to that, we saw that the amount of geographic atrophy was more in the Lucentis arms, and especially monthly more than PRN. So is that a concern?
Not as yet.
Okay.
But, this thing is now going to, when you're talking of real-world experience, that's when the atrophy came out. It didn't come out because that takes time to come up. But, I really don't know the answer. You're dealing with a devastating disease, which is progressive. So the first misconception is that when you treat neovascular AMD, that it comes to a standstill. It doesn't. It just slows down. And atrophy is just part of the process of advancement of the disease. Whether it accelerates or not, I don't think we have the data.
We have the data. Okay.
So even in the CAT study, the association was not causative.
Yes.
So
No, it was not causative, but the p-value was significant. There was a 25% difference
but that
between
could also
Lucentis monthly as well as Avastin monthly. So about, once you get a grip on the disease, maybe should we step off a high dose molar concentration to back to regular, because you see the equity difference was not much. The only benefit was in the durability. So we have hit a very high bar with efficacy. So durability is now what everybody is looking at.
So to back your statement further, actually, if you see the VIEW trials, in VIEW 1, the results are uniform that 2 milligram 4 weekly is great. But if you see the results of VIEW 2, which has Asian patients and Indian patients, the results of 2 milligram 4 weekly is the worst in terms of visual outcome, but not in terms of drying of the lesion. So seeing the combination, lesion dries, vision does not improve, actually gives me an idea that maybe there's more atrophy in Asian patients with too much of Aflibercept. And they got better results with 0.5 milligrams. So with 8 milligrams, it's possible that maybe in Asian patients it'll show up before it shows up in Caucasian patients.
No, I think these are things that time will tell and nobody else can. Yep.
Yeah.
Okay, so now we have, after this, we have Dr. Malika. She's going to be talking about her approach to retinal vein occlusion. And in the meantime, if there's any other question anyone wants to ask. Babu, you're quiet for a very long time.
Dr.
We were
Verma,
expecting you to ask something at least.
Yeah, I was wondering
And Naresh?
from the few cases that you showed, was your experience better with this 8 mg than with faricimab? Would you say that on the that's a better or a more efficacious drug, and also duration?
The sequence of events was that we got faricimab before we got Eylea 8. And anyone who's stable on faricimab, there's no indication to move them to Eylea 8 in any way.
Yeah.
So in terms of equivalence, you look at two things. Initial response, which means how soon you can get the anatomical parameters better, and the durability. I have a feeling, because I had more patients on Eylea, I just switched them straight to Eylea 8. But I think this question as comparing A with B in the real world, maybe, where's your next AIOS?
Jaipur.
I might have something more than at that time, but right now I don't know.
Okay. Because that's really the most important question for us is whether it's better than faricimab. Can we start the slide? Then, yeah, there's some more questions. Yeah, one more question for Dr. Verma.
Look, have you done PDT? Have you ever done PDT? No, okay. If you wanted to see rips, that's when you used to see rips. You know, those were the real rips. But once we come on to the anti-VEGF era, you know, it was so bad at that time we were scared of doing PDT in patients with PDs. But with the anti-VEGF agents, the rips are actually very, very uncommon. And same thing with Eylea, whether it's 2 milligrams, 8 milligrams for faricimab, I don't think there's any worry about rips.
Incidentally, it's going to take time for you to see rips because most of these patients are shift patients. And usually rips happen in the first injection or two. So a patient who's taken up for, who's been on Aflibercept and is now shifted to faricimab or high dose is unlikely to get a rip. At that stage, it goes away.
Yeah.